So I'm going to talk about cancer screening and start by saying that around 1 in 4 adults with IIM develop cancer. And strangely, this is in the 3 years before or after IIM onset. Outside that time, people with IIM have the risk of cancer similar to the general population. And this is really any cancer. So typically breast cancer, lung cancer, colon cancer, a particular increased risk of ovarian cancer and lymphoma as well. We see an association with melanoma as well. And as I mentioned earlier, this is another reason why it's important to do the top to toe examination when you see a patient. Now, last year, we published the very first evidence and consensus-based guideline on cancer screening in IIM. This was a big effort that took the input of, I think it was 72 international experts from 22 countries. And this is the first time that we've had consensus evidence on how to screen for cancer. You can scan the QR code there. If you want, it'll take you straight to the paper. So this is within the paper. This is the flow chart that kind of encompasses all of the guideline. So if we start at the very top, we take people with an IIM diagnosis, and we're only considering people within the 3 years after symptom onset. Obviously, we're never going to see someone with the cancer before the IIM onset. This is only the people who have the IIM diagnosis without a previous cancer diagnosis. Now, children, juvenile onset, cancer screening is not routinely required. The same for inclusion body myositis as well. So we can then identify some cancer risk factors based on IIM subtype, the MSAs, and the clinical features as well. So each column we have high risk factors, intermediate risk factors, and low risk factors. I'm just going to pick out some of these. So dermatomyositis, that's a high risk subtype. TIF1, NXP2, they're high risk autoantibodies. And clinical features that are high risk: onset over the age of 40, persistent high disease activity, dysphagia, interestingly, and cutaneous necrosis. Now, intermediate risk factors: clinically amyopathic dermatomyositis, polymyositis, IMNM. A number of different autoantibodies are intermediate risk. So SAE1, H&GCR, Me2, and MDA5, and male sex as well, intermediate risk. Low risk factors: antisynthetase syndrome, CTD-associated IIM. The low risk autoantibodies: SRP, JO1, any other antisynthetase autoantibodies, and a myositis-associated autoantibody. Interestingly, Raynaud's, inflammatory arthropathy, and interstitial lung disease are low-risk clinical features. So the idea is that you can add up and tick which clinical features your patient fulfills. We then say that all patients with IIM, so irrespective of their cancer risk, they should continue to participate in country and region-specific and sex-appropriate cancer screening programs. Now, if someone has 2 or more high-risk factors, they're then deemed to have a high risk of IIM-related cancer. So, for example, if someone has dermatomyositis and TIF1, we deem them to be high risk. So we recommend screening at the time of IIM diagnosis using the basic and enhanced screening panel. And you can see down here the basic panel and the enhanced panel. So the basic screening panel includes things like plain chest X-ray radiograph, protein electrophoresis, comprehensive history and examination. A lot of these may seem simple, but it's good to confirm and that these things need to be done. You can pick up a melanoma, you can pick up an enlarged lymph node, for example. The enhanced screening panel includes a CT scan of the neck, thorax, abdomen, and pelvis, cervical screening, mammography, prostate-specific antigen, for example. So in people who are high risk, we say that they need to have the basic and enhanced screening at the time of IIM diagnosis. They then need to have the basic panel annually at 1, 2, and 3 years after IIM onset. So we don't recommend repeated CT scans. That's because of the lack of evidence and the radiation exposure. Now, in people who are high risk, you could consider just using a PET-CT scan instead of all of these screening methodologies. If PET-CT scan is freely available, you can get that in a timely manner. All of these can replace all of the other screening approaches. You should also consider upper and lower GI endoscopy. There's no evidence to suggest that this is beneficial in patients with IM, and there are potential side effects, but you should consider this. That's high risk. Now, what if someone doesn't have 2 or more high risk factors? We go down here. If they have 2 or more intermediate risk factors or 1 high risk factor. So someone may have IMNM with HMGCR positivity, or they may have polymyositis that begins over the age of 40. We deem them as being intermediate risk. Sorry, we deem them as being moderate risk, and we then advise screening at the time of IIM diagnosis of basic and enhanced, and we don't recommend any repeated screening. If people don't fulfill the high or moderate risk categories, then we deem them as being standard risk, and we say just to do the basic screening panel at the time of IIM diagnosis. We also make a recommendation to consider screening for nasopharyngeal carcinoma. This is particularly prevalent in Southeast Asia, so we advise people to consider nasoendoscopy to look for nasopharyngeal carcinoma as well. So let's put this in context. So we're back again to Mrs. Jones, who we met earlier. She's a 70-year-old female with dermatomyositis, began 8 months ago, NXP2 positive, and a raised CK of 4,250. So what's her cancer risk? Well, she has 3 high-risk factors: DM, NXP2, onset over the age of 40. So we deem her as being high risk. So she needs basic and enhanced screening at the time of diagnosis, and then this basic screening panel annually up to 3 years after. And for her, we could consider a PET-CT scan. Mrs. Sinclair, she's a 52-year-old with IMNM, anti-HMGCR positive. What's her cancer risk? So she has 1 high-risk factor, so that's not enough to fulfill the high-risk category, and she has 2 intermediate risk factors. So she's moderate risk. So we would advise her to have the basic and enhanced screening panel at the time of IIM only, no repeated screening.